Hi, welcome to The Vitals, Mount Sinai Health System's newest video podcast. I'm your host, Leslie Schlachter, and I'm a neurosurgery physician assistant here at the Mount Sinai Hospital. Today, we're here to talk about the Surgeon General's new advisory on alcohol and its risk for cancer. Today, we're going to talk to ENT and colorectal surgery about its risk of developing mouth, pharynx, larynx, and colon and rectal cancer. We all know that alcohol can cause things like addiction, dependence, withdrawal, and even for some people, some social and economic consequences. But today we're going to learn specifically about the signs and symptoms of what to look for these cancers, when to treat, and what those results of treatment are. As a neurosurgery physician assistant, I can definitely see the difference between a healthy brain on a scan versus a brain in someone who's had a long time of alcohol consumption. It can lead to specific changes, and in the patient, you see cognitive changes. So I'm looking forward and excited to hear about these changes that we're going to start having to look for now that we know the specific connections between alcohol and these cancers. All right, I want to thank you guys all for being here. Let me introduce you. First, we have Dr. Benjamin Laitman. Do you prefer Benjamin or Benny?
Benny's good.
Benny. You're an assistant professor in the Department of Otolaryngology-Head and Neck Surgery at the Mount Sinai Health System. We have Dr. Sue Hahn, an assistant professor of colon and rectal surgery at the Mount Sinai Hospital. Thank you guys all so much for being here.
Thanks for having us.
Happy to be here.
So what we're going to talk about today is the Surgeon General's recent advisory on the link between alcohol consumption and cancer. To kick us off, the recent advisory from the U.S. Surgeon General and medical experts have underscored the significant health risks, emphasizing its classification as a toxin and a carcinogen, specifically increasing the risk of mouth, throat and pharynx, voice box or larynx, breast, colorectal, liver, and esophageal cancer. So are you guys ready to talk about this?
Sure.
Always.
Benny, let's start with you. Is this advisory surprising to you?
No, I mean, it's definitely something that we don't take as seriously as smoking cigarettes. It's not one of the major things we're kind of looking for as one of the prime drivers of cancer in the throat, but it's not surprising. I mean, this is a caustic agent. There's a lot of factors that can change on a cellular level, and your mouth, your throat, back of the throat, this is the first point of entry where this is touching. So it's not surprising that given all the factors that we know about alcohol, that it's going to have some effect and cause on cancer.
What actually happens with alcohol and how it leads to cancer?
Well, alcohol is broken down into a metabolite that can then lead to creation of oxygen-free radicals that cause stress, inflammation to the mucosal lining or the inner lining of the colon and rectum. And any kind of long-standing inflammation can lead to overgrowth and thus carcinogenic tendencies in terms of leading to cancer.
So, all right, I just want to put this all in my head because it sounds like your mechanism is a little bit different than her mechanism. So you said alcohol actually entering in and hitting the mouth, the larynx and pharynx and those airways is actually causing the issue, but yours is like the breakdown products of it for the colon and the rectum. Is that about right?
Well, by the time it reaches the colon and rectum, it's been broken down, right? It's been digested, it's been broken down to smaller components, and something along those components causes inflammation. And that's kind of the underlying thesis of just how cancer develops in the body. And the other aspect of it is we know that in the colon cancer creation aspect is that there are certain types of DNA breaks and damages that have to happen in certain genes to lead to colon cancer development.
So is it similar in the larynx, or is it actually the alcohol itself damaging the cells?
It's a little bit more. I mean, in the mouth and throat and everything like that, there's a little bit of the breakdown products, whatever is entering in the body, obviously, but there's a little bit more of a caustic effect and a direct tissue injury that's occurring, as well as interaction with other known carcinogens that kind of either we're inhaling or eating and mixing with the alcohol and further damaging the tissue.
So I'm sure one of the questions that people has is there any alcohol that's better or worse? So your patient comes to you, they're like, Dr. Laitman, I'm not going to stop drinking, but just tell me which is the least offensive. What do you say to that?
Unfortunately, they're all the same at their base. Alcohol is alcohol. Obviously, there's wine, liquor, beer, different tastes, but the actual agent that's causing the issue is the same in each.
So you're saying that someone who drinks Michelob Ultra, 4 on a Saturday night and a Friday night, it's the same level of injury as straight vodka?
Yes.
Okay. That's important to know. Let's talk about the signs and symptoms of cancer and what patients should look for specifically, because I feel like people know that if they've been drinking for years and they turn yellow, maybe they should see a liver specialist. But what, in your world, are the symptoms that someone would look for to say, like, hey, something might be wrong?
Yeah. So some of it is what you see. So if you look in your mouth and you see something funny, a bump, a big ulcer, something that's not getting better, that's obviously something to look out for. If you notice any sort of odd lumps and bumps on your neck, growths that weren't there previously that haven't gone away, that could be a sign of a cancer that has actually spread to some of the lymph nodes in our neck. Issues with swallowing that are persistent, including weight loss, changes to the voice or breathing are some of the big things that, along with known exposure to long-term alcohol or smoke, would prompt referral and sort of evaluation.
Yeah, I would imagine you can't look inside your own colon or rectum, but so what would patients be feeling? How would they know to come see you?
So the primary symptoms are if there's any changes to the bowel movements, if there's narrowing of the stools and caliber, if there's any bright red blood or dark blood, and signs very similar to the oral cavity. If you have extensive like weight loss that's unintentional, being tired all the time. Luckily, with colorectal cancer, there are screening guidelines for the general population, and recently it's the age of screening for someone who is at average risk, meaning no increased family history, no other predisposing disease. The age dropped from 50 to 45, and that's been a pretty significant sequelae of all the research that's been done in the past and the trends that we're seeing nationally and internationally, that there are younger and younger patients who are getting cancer when they otherwise have no risk factors for it.
Are those cancers that they would need to be worried about, or are those cancers that were like, oh, we picked it up early, this will be okay?
Well, the scary thing is a lot of the younger onset cancers are before they would have even started screening.
That is scary.
So that's the concern.
Do you think
part.
That's because of alcohol, maybe? Do you think there's a connection?
There's so many factors that go into colorectal cancer development that it's probably a combination of a lot of factors. Maybe alcohol does play a major role in that. We know diet, other processed foods, like who knows about these microplastics. There's a lot of things that are just in our general environment and our diets and everyday lives that may be impacting that. And I think alcohol probably has a hand in that as well.
So that's kind of lucky for her specialty. So she has screening guidelines. You don't have screening guidelines for ENT. Not. So you just have to hope that like someone comes in if they feel like something's wrong.
A little bit. I think that if you have a good relationship with your primary care physician, if you note any sort of changes, it's something to bring up. I think, unfortunately, we don't have the same, guidelines. We know that folks are getting cancer at younger ages. We're seeing it in relationship a lot to, in our field, smoke, HPV. We don't know the impact of alcohol truly on the field, and we're at a disadvantage in sort of not having regular screening guidelines.
Is it multiplicative, meaning worsened? Like, so if you have someone who's drinking and smoking, let's just not do HPV for right now. But does drinking and smoking make it worse? Is it like a more aggressive type of cancer?
Absolutely. There's a known additive effect when you have the two. Yeah.
Is there a difference between, this is for both of you, the type of cancer that you would see just in someone who's not drinking versus someone where it's maybe a more alcohol-related cancer? Is there a difference?
Not so much. I mean, there are obviously various types of cancers. The ones in the throat are, as I mentioned before, kind of more a caustic effect, injury to the surface and sort of cancer developing there. And so that's really just any irritant. Alcohol is one of them. So
I would imagine somebody who has that from alcohol and they keep drinking and they're just making it worse and worse.
Worse and worse. It's kind of just burning the top constantly, and it keeps getting deeper and deeper and deeper without allowing the tissue to heal.
Okay. What about for you? Any difference between like alcohol-related colorectal cancers and non?
Not that we know of. Not yet. Hopefully, we figure that out. But in terms of from our standpoint, cancer is a cancer. There's different types. Yeah. But the most common one, which is adenocarcinoma, there's no difference to tell us where this exactly came from, what caused it. It's just the fact that it's there.
How do you treat? You said adenocarcinoma. How do you treat that?
So if it's in the colon and it's what we call locally advanced or just surgically resectable, then surgery is the primary mode of treatment, and then plus or minus chemotherapy if it's shown to have spread beyond that to the lymph nodes in the area. For rectal cancer, it's a little different because of the confinements and anatomy of the rectum in the pelvis with all these other structures. And so for rectal cancer, primary mode of treatment first is neoadjuvant chemo and radiation.
Neoadjuvant meaning like before you have the surgery,
then you do the surgery.
So you're like
and
shrinking it so that you can get more during surgery.
Yeah, that's been shown to decrease the local recurrence rates after the surgery later on.
Is that similar for the type of cancers you treat?
For us, it's multimodal. So often surgery is our primary kind of what we try to do. But in the head and neck, we have to consider not just the resection of the tumor, but return of function, cosmesis. I mean, if you have a large, bulky tumor that involves aspects of the jaw, you have to take out the jaw. You have to put something back, or else people can't eat, drink, speak, breathe. So not only do we have to do the surgery, we have to focus on the reconstruction, but as in sort of colorectal, we have adjuvant treatment, so the treatment after of chemotherapy, radiation as add-ons depending on the degree of spread or locally as well as metastasis to lymph nodes. In some of them, radiation could be the primary and you could shrink the tumor, but that is sometimes related with long-term issues in function down the line or secondary tumors that develop from the radiation itself.
So as a physician assistant, I've worked in urology for many years and now neurosurgery. I've seen patients with a host of deficits. Can you talk through, I kind of want to like instill a little bit of fear into our listeners who are drinking, right? It's not just like cancer treatment, you're going to be okay. Yeah. These deficits are real. So can you talk a little bit about like how it affects people's talking, chewing, breathing, sometimes people are going to need bags and tubes. Can you talk a little bit more about like what those deficits look like and how they're managed?
Yeah. So for example, let's say someone has a larynx or a voice box cancer and we have to take out the entire voice box. That means you cannot speak to any normal degree. You will ultimately have a permanent hole in the front of the neck where that's where you have to breathe through. And you can still eat and drink, but that can often be very severely restricted. You may be able to speak again, but it's what we call burp speech, or it essentially sounds like that, or the old school electrolarynxes where you can they sound a little bit like that. So it
like almost robotic.
Yeah, it
so
completely alters that quality
and what
of life.
percent of patients are like gonna, when you find them, they can actually have treatment and look and feel normally versus end up with a significant deficit like that?
If it's earlier, for voice box cancer, for example, you may just get away with having an altered voice and everything else is pretty much normal. Not completely altered, but it, a little
like
bit
kind of hoarse sounding?
A little hoarse, but otherwise not bad. But as things kind of grow, and especially all these additive effects, if you drink a lot or have other sort of environmental exposures, sometimes it gets out of control where we can't. And the only answer is either, total removal or chemotherapy with radiation, which also has sort of long-term negative effects.
Yeah, and I'm sure you hear this a lot from your patients. I don't want a bag. But like, we know bags as healthcare providers aren't the end of the world. Like, what should patients expect if they have to have like major resections and treatment?
So it really depends on the location of the tumor. If it's more what we call proximal, in the abdomen, not so low and towards like the rectal aspect, we can remove it, put it back together, reconstruct, and it's not that bad. You're not going to notice a huge change in your overall life. But if it is more of a rectal cancer, particularly a low one where it's very close to the sphincters or even involving the sphincters themselves, then you're looking at either a permanent ostomy, which is like a poop bag, permanently, and that's obviously has its own quality of life issues and stigmas and so on. So patients tend to get embarrassed and it's something that they have to live with. Or if we can resect but preserve the sphincters, now you've lost the rectum's special capacity that it has, the stretchiness of it to act as a reservoir to be able to let you hold your stool before you have to go. Some people don't have that capability anymore because now we have to reconnect colon to the sphincters, and so it doesn't have that stretchiness anymore. So now then you're looking at patients who have something called low anterior resection syndrome where they're feeling tenesmus or spasms all the time. They have incontinence sometimes. They have to run to the bathroom.
That's totally life-changing.
Yeah, it's completely life-changing. It's something that is it's a long conversation and a long road to to try to get them into a position where they figured out their regimen to live a fairly normal life. It impacts them.
What trends have you seen in your practice as far, so obviously this advisory came out because they're seeing a trend with cancer. Are you seeing cancer being diagnosed, like I know you said earlier stages, but are you seeing maybe those who consume alcohol coming in later and later? Or is there not really a connection with that?
We haven't gotten to that level of granularity in terms of alcohol-related cancers versus not, and is that particularly the thing that's driving these early onsets. So overall, in terms of earlier onset cancers, is something that, we're just much more mindful of. My threshold for a colonoscopy is much lower now. Mm-hmm. Even myself, I got myself a colonoscopy before I was supposed to, and I have polyps, and I don't have a family history. So it's something that we're very mindful of, and anything that previously would have said, oh, it's not in your age range, we would probably more likely to investigate a little bit further.
So Benny talked a little bit about the risk factors like alcohol, smoking, HPV. What are some other risk factors for colon cancer that we should know about?
Some things are diseases that you have, like in terms of inflammatory bowel disease. That's one, ulcerative colitis or Crohn's disease. Smoking, drinking, like we discussed. Having a diet that's high in fat, red meats, processed foods. Anything with nitrites or nitrates, or like barbecue, kind of, all the good things in life. Those are things that actually kind of increase your risk for cancer, especially if you have any of the genetic, colorectal cancer syndromes. There's a whole host of genetic diseases that increase your risk of lifetime cancer to even up to 80%.
Is that like a BRCA thing for breast cancer? Is there like a gene for colorectal?
Similar. There's an APC gene. That's the first gene that's mutated on the way to developing cancer.
But how would someone know if they have that?
So there's usually a family history of it. Either they have something called familial adenomatous polyposis syndrome, where they have tons and tons, like innumerable polyps.
So a family would know this generally.
Family would know this. That would kind of prompt the family member, the first degree family members, to get screened earlier at an earlier age. Or if they undergo genetic testing, then that prompts the genetic testing of their family members.
Mm-hmm. Earlier you did, so let's just go back to the HPV thing for a second. And I think it's really important, not just HPV, but just to talk about sexually transmitted diseases. Can you talk a little bit about those as a risk factor also?
So throat cancer, so back of throat cancer, tonsil cancer, back of the tongue, historically was known as a smoker's cancer. And what we've seen is that over time, it's actually, as we've gotten over, as some of these guidelines have come out about smoking and smoking has decreased, that's been less of a cause of cancer. And now we're seeing a shift actually as HPV being one of the prime drivers of throat cancer in general, especially in men. And it's often, not thought to be HPV is a sexually transmitted disease. We think it's not going to affect men. We know it's involved in cervical cancer and cervical screening. And so for a long, and most of the, vaccines were not given to men early on. And so it really wasn't seen as a male disease, but we're seeing this kind of surge in HPV-associated oropharyngeal or back of throat cancer in men that is kind of now overtaken cervical cancer as the prime HPV-associated cancer. So it's one of the main drivers of throat cancers, and luckily it's treatable, and preventable with vaccines.
Is it a different type of cancer than? Like the cancer that's caused by HPV, is it a different type of cell than the other cancers?
It's all the same cells. It's all what on a basic level. We have skin on the outside, we have skin on the inside. It's the inside skin of our mouth and our throat. It's all very similar. And the same cells are getting damaged when it's smoke or it's alcohol. It's causing some injury to those cells that maybe they're then kind of going a little bit haywire. HPV is a virus, and it's actually integrating into the cells and changing its DNA, and that's why they end up sort of replicating and growing out of control. So it is a same cell, but different insult.
So interestingly, for ENT and colorectal, we work on the opposite ends of the body, but we actually have a lot of HPV induced like anal cancer. And so we deal with HPV all the time. And I was talking to some of your colleagues about like how, it's such a weird transformation that, now this is a big rising trend in throat cancer. But for us, like it is different for us. The HPV is usually stems from like the anal canal, which is where there's a transition of types of cell from skin to what is more glandular or more like the rectum, and that's where a lot of these cancers are being found. And so the types of cancers are actually different for us, but still in terms of everything, HPV is a major driver, and it's very similarly. It wasn't really a male kind of disease, but now, we're more aware of it, and now, we're trying to get everyone to get their vaccines. And there's a new one that actually has 9 valence, which is even better. So even people who had the original 4 valent should update to the 9.
What you mean by valent, so there's different strains of HPV.
Mm-hmm.
So you're talking about various different strains that can lead to the cancer. And just to be clear, because we're talking about like oral cancers, rectal cancers, when you guys are talking about men, are we talking specifically about male sex, oral intercourse? Can you guys talk a little bit about like ways that we can improve this? Because there's like, I know when I was growing up, I had like health class, they talked about like dental dams and using condoms for oral sex. Like, what are ways that we could actually try and avoid this?
I mean, it's one of the most prevalent viruses out there, and it is sexually transmitted. So it's any form of intercourse, oral, and anal, vaginal, any of that is where it can come from. So there's no real. The major prevention, honestly, is the vaccines out there, and it is the guidelines on those have shifted. It used to be for women of a certain age group, then that expanded to a larger age group. Now it includes men. It's now, I think, expanded into the mid-40s in terms of who can actually get the vaccine. So it keeps expanding because most people are pretty much exposed to this throughout their life, and it's unclear. Most of us clear it. And some of us don't clear the virus, and that.
Say that again.
Yeah.
If you're exposed to the virus, many people clear it.
Yes.
Okay.
But not everyone does, and we don't know why certain people do and why certain people don't. And if you don't, that's when it starts messing with the cells and turning them into precancers, cause dysplasias, and ultimately cancers. And so
maybe it's alcohol consumption.
We don't know, right?
Right,
it could
right.
be. It could be these other interacting things in our body. We don't know that type of stuff yet. We just, we do know that this is one of the risk factors.
Right. Okay, so how are patients finding you, right? You talked before about somebody might be having symptoms, they go to their primary care. How do patients end up in your office? Is it their primary cares? Are patients calling you directly? How do they find you?
Yeah, so it's a little bit of a combination. My focus is mostly on the throat itself. And so when people have changes to their voice or breathing or swallow, they'll either come directly to our specialty within laryngology, or a lot of times this is primary care doctors that are picking this up, and they have the intimate, they know their patients, they've known them for years, and say, I hear your voice sounds weird now,
yeah.
Or you're losing weight, or what's going on, and that's really with some of these associated risk factors like heavy alcohol use really should prompt a primary care physician to say, I think this is now you should see somebody that can take a look. We can take a look very easily with various cameras in the office and tell you very quickly whether or not we see a cancer on the surface. It's a quick sort of check.
Is it the same thing for you, like people coming in for their checks, or is it patients calling and saying, I think something's wrong?
It's similar to what Benny's saying. So primary care doctors will notice something. Usually some kind of colonoscopy is prompted, and then once the cancer is found, then that's when they're usually referred over. In terms of anal cancer, it might be a little different. Some people will come in because they thought it was hemorrhoids, and that's a very common thing that people are referred for. And, just today I was seeing a patient where she came in with an anal polyp. I removed it. It turned out to be cancer. And so, that was kind of a lucky thing that we were able to catch it really early, but not everyone is like fortunate in that way. Some people go on thinking, oh, my bleeding's from hemorrhoids for many, many years, and then it becomes, something that is much bigger or more advanced. And if we had found it sooner, or medical attention was brought sooner, then we could have done something a little bit differently.
So I guess the big difference between you guys is like patients can just be worried or concerned or feel like something's wrong and make an appointment to come see you. But they generally have a cancer diagnosis, and you're going to be the one managing it.
Usually, yes.
Yeah.
Yes. Unless they came to me specifically for a screening colonoscopy, then I'll be the one doing the colonoscopy and finding it that way.
Yeah, we're lucky in the sense that not everything that causes your voice to be hoarse is cancer. In fact, most things aren't. But again, when you have these associated risk factors, you always got to rule it out.
Yeah. I mean, I know I refer patients to you. There's in neurosurgery, tumors can grow on or around nerves that affect like swallowing and talking and all these things. And sometimes having a hoarse voice is the first symptom of even just a benign tumor.
Yeah, exactly.
Yeah.
But a benign tumor that's just in the wrong location that's
Yeah.
giving you problems, for sure.
What if you could give like your own personal advisory to your patients, like knowing that like you know what you know about how aggressive these things can be and the treatment sometimes? What's kind of like your own personal advisory for warnings for specifically alcohol and its relationship to cancer?
I mean, in terms, alcohol is something that's part of the culture and it's very casual, especially I feel like in medicine.
Yeah.
A lot of people
Yeah, we don't
partake-
even have like holiday parties without alcohol.
Yeah, no.
Right.
I mean,
Exactly. But, I'm a strong believer in being a realist. Things in moderation, don't go overboard, try to limit as much as you can. And it's really hard for anyone who's used to doing something every single day to stop cold turkey. That's the hardest thing to do. So start baby steps, one step at a time, decrease, limit your intake, and then slowly, eventually replace it with something that would, kind of still give you a little fizz. If you like beer, switch to like seltzer, something else that can maybe replace that's not as harmful. Right. And that's a more, I think, realistic way to get patients or other people to change their habits.
no, I mean, I think these guidelines, it's, I'm a social being and I have friends and family, and it's even making me rethink things and how much I drink personally.
How much do you drink personally?
I'm in the maximum, the 7 a week category, not all every week, but like I'm not.
Is this like a 1 drink a night type of thing, or like on a Friday or Saturday night,
It
2 or 3?
depends on the week, because if a friend wants to go grab a drink after work, or I'm going to see friends on the weekends, I have 2 young girls. We all our parents when we have babysitters, we go out, and that's the reality. And like you said, this is part of the culture, but it makes you think. I have 2 young girls, and I want to make sure I'm around for the long haul. So, maybe it's cut back a little bit. And I do think, everything in moderation. Try to find a way to cut. Try to find an alternative. It's impossible to go cold turkey, but also don't beat yourself up if you're not perfect. I think that's the other thing. We all have our vices in life, and we have to improve, any one of us. But, just try to do better.
Yeah. The guidelines are very specific on like men are allotted more than women.
Yeah, I get one.
Not taking into consideration.
I get one a day.
Yeah, like I get like nothing, but they don't realize I'm 6'4" and I weigh 200 pounds. So I think mine are going to be like the male guidelines. But you kind of touched upon it a little bit. Like if you like beer, maybe something fizzy. If you had to give up alcohol, if you're going to give alcohol, just say you're giving alcohol up completely. Mm-hmm. What would you say are some like your personal, like, how are you going to replace it? What are some good ideas how you think you can replace it? Instead of meeting for happy hour, maybe do something else. Yeah,
I mean, like, luckily we live in a day and age where there's a lot of substitutes for things. Yeah. So there's a lot of companies out there that are creating these mocktails that kind of taste like the alcohol but aren't alcoholic.
I love a mocktail.
So I mean, and the bars, even at the menus, you see there's a much more expansive mocktail menu than there used to be, where it was just like seltzer water and like some orange juice or something like that. Mm-hmm. So that can help replace like the taste if that's what you're kind of going for. And in terms of my personal habits, I'm not much of a drinker. I drink maybe like 2 a month. But again, social contacts, of course. But those are things that I think can be part of the plan to cut down in terms of alcohol intake.
Let's say somebody wants to replace their alcohol with cannabis. Good decision, bad decision?
Don't smoke it.
What's your preferred route for cannabis?
I work on the voice box. Smoke and heat screws with your voice. It can those types of things are carcinogens.
Okay, you said smoke and heat. What about vape?
That has the heat. Even the cool, I don't know, with the oils,
As the kids, they call them carts,
So the vaping probably has various oils that can be problematic. Right. We know there's like vape lung or different things like that. So eating is probably the best route.
How do you feel about eating?
Granted, I don't know. Like, that's like, I don't know. Maybe I'm
like, are we going edible over?
Maybe I'm kicking the can down the down the road here.
Down the colon. Yeah.
I mean, like for me, I'm like a huge fiber nut. Like I get med students, shouting me all the time. They're like, "So how much fiber do you start off with?" And
how
by
much
the
fiber
end,
do you take in on a daily basis?
I take at least 1 tablespoon of Metamucil every single day.
How many grams of fiber is that?
So it depends on the spoonful, but usually about like another 12 grams.
So if you take a cannabis-infused fiber supplement, is that reasonable?
I don't even know how to answer that. But
So-
better than smoking, probably.
Yeah.
Yeah.
Yeah, definitely, probably better than smoking. Yeah, I mean, because I think that's like when this advisory came out, my own children, one of my children, was like, well, what's a better alternative? And my answer was, I don't know, like a Michelob Ultra instead of vodka. So clearly now that's not a good alternative. But he did say, like, what about cannabis? And I'm like, can I get back to you on that?
Yeah.
Like, it
I
is
think-
hard.
We don't know. Jury's out on a lot of things. Ultimately, probably lesser of two evils.
Okay, so we're going mocktails.
Mocktails are
I'm
probably
going,
good.
like,
Although then
reading,
you get into sugar,
gym,
but then
and
you get into sugar. So and processed sugar. I mean, which is maybe, who knows, maybe worse than alcohol. I mean, so
Right, so if we're going on long walks, potluck dinners, and going to the gym,
Eat
those
some
are our
broccoli
replacements.
and go for a run is probably the best answer. Yeah, that's fiber and greens and exercise. Doesn't that sound great?
Sounds like so big crudité party.
Yeah.
Yeah. No, it is. It is. I hope that this advisory coming out is similar to what happened with smoking years ago, because now like the general public will say like smoking's bad for you. I hope that same thing happens with alcohol, because it seems like that's the direction we're heading in with all these warnings. So is there anything else that you want to share about your practice? Anything that you feel like we didn't discuss today?
No, I think that ultimately, if you're worried, if you know yourself, and if you feel like something's off, go see someone, get checked out. Don't delay it. That's, if something is bad, then we can miss it. If everything's fine, then we get to tell you everything's fine, which is awesome as a doctor to be like, you're good, go home. Right. So if you know yourself, if you feel like something's wrong, go get checked out.
Okay, and for you said guidelines with nothing wrong, 45 colonoscopy?
Unless you have a risk factor such as a family history of something else, or one of the other diseases that we kind of touched upon that increases the risk of colon cancer.
Is excess alcohol intake now considered a risk factor?
Not yet. No.
Not yet.
But I'm feeling it might.
Let's say you get someone calling the office saying like, hey, I've been drinking like 30 drinks a week and I'm 44.
I mean,
I'll
I'll probably
push that one through, right?
Yeah.
Okay. Anything else that you feel like we didn't talk about today that you want to share?
Similar to what Benny said, don't delay. If you start noticing something that's a trend and it's not normal, like bleeding and other things, like get yourself checked out, and then you'll have peace of mind if you do get checked out. And especially for our standpoint, colorectal surgeons, we deal with an orifice that's a little kind of embarrassing for people, but it's not. Like, people just don't talk about it, but a lot of people have similar issues and they just don't talk about it in a social setting.
Right.
But it's pretty common for people to have issues.
So if alcohol is a risk factor for getting cancer, is it a higher risk for those who drink vodka versus those who might drink beer? What's the story?
Unfortunately, it's all the same. Alcohol at its base is alcohol. Obviously, you have wines, beers, liquors, and they taste a little bit different, the things we add in, but the underlying chemical that is the carcinogen is the same in each.
That's unfortunate.
Yes.
Yeah, same for colorectal cancer?
Mm-hmm.
Doesn't matter?
Mm-mm.
All right, well, I guess we don't have to change what we drink if we're going to drink. So I want to thank you guys both for being here. I think this is going to be really helpful, not only to our listeners that might be patients not in healthcare, but for people that are in healthcare too. They might have learned signs and symptoms to look for and know when to make a referral. So thank you for being here.
Thanks for having us.
Absolutely. Thank you.
So we learned today that because of this Surgeon General's advisory, this new warning, that there is an increased risk of getting cancer with alcohol consumption. 1 drink a day, generally okay. But if you're someone who's been excessively drinking for a long time and you have any concerning symptoms, like difficulties swallowing, eating, speech, the quality of your voice is different, if you're losing weight, any change in stool pattern at all, these are all things to bring to the attention of your primary care doctor or make an appointment to see a specialist. And I think the most important thing that we learned today is that getting in to see a doctor sooner and possibly finding something could mean much simpler treatment and much easier for you to recover from. The longer you wait, the more advanced a disease is, the more difficult treatment might be, and the more, unfortunately, deficits that you can suffer from, which could be quite debilitating and possibly even embarrassing. So bottom line, get checked.